So today we have with us Professor Rudolf Stadler, who joins us from, well, today he's in Hamburg, actually participating in an oncology, dermatology oncology professional conference. So he stepped away to be able to join us this morning. So welcome, Professor Stadler.
Thank you very much for your invitation. Pleasure to be with you all.
Yes, and he is from Minden and one of our cutaneous lymphoma experts who has been in the field for quite a long time and has participated in a lot of the research initiatives and is very active in our international clinical community. So it's really delightful to have Professor Stadler with us. And we have Dr. Kevin Molloy, who joins us from Dublin this morning, and Dr. Molloy is also a cutaneous lymphoma expert and is bringing his expertise to Ireland. He's been very active in the cutaneous lymphoma clinical realm and has a big passion for quality of life in patients with cutaneous lymphoma. And it's really a delight to welcome both of you to our live Q&A today. And hopefully we won't throw any big curveballs your way, but we'll do our best to condense some of the questions because some questions tend to be similar, right? Especially the ones that have been sent in prior to when folks registered. We've got a whole list of questions, so we'll do our best to get to everything. Also, just to let everybody know, the clinicians here cannot address any very specific questions about your iteration of the disease. Obviously, they're not your physicians. So if you can and you have a question, try to keep it a bit more general and we'll do our best to answer, but just know they can't make any comments on your specific disease iteration at this point in time. So, okay, so let's get rolling. Very, very excited. We've got a couple of questions. Let's start off with some that are probably more general in nature, but we've got some questions around sun exposure. And does that help, or is that cause more problems with patients with cutaneous lymphoma? So I'll toss it out, and Professor Stadler and Dr. Molloy, you guys can decide who wants to answer first or go back and forth, however it works for you. So sun exposure, is it helpful? Is it harmful?
No, it's in my opinion, and I think generally spoken, it's helpful. In ancient times, Egypt was born the traditional enhanced light UVB therapy with the compound formerly mentioned as 8-methoxypsoralen as photochemotherapy. So, and this was a long stay of therapy to enhance light therapy for patients. And we are living, and Kevin Molloy also more in the north than we are in Germany, but still we have not too much sun. So we have to send our patients to the southern parts. And there was always a recommendation for patients to use their free time to join regions where they can use intelligently UV, not to burn, but still to go to the ocean and to have a salt bath and then the UV. That's always helpful.
And from a more northern latitude, we certainly with an Irish population, it's always that word of caution about being careful in the sun and not burning and sensible UV exposure may be helpful.
Right. Always a balance. Always a balance. Wonderful. So we have some questions with regards to, can mycosis fungoides improve spontaneously? Any thoughts on that?
I think we see that in practice where it can wax and wane, where the patches can come and go. And I think that's what I find very interesting in terms of mycosis fungoides, is you can see that interplay between the disease and actually the immune system, patient's own immune system, trying to control the disease at any one time. So you do see that definitely with patients.
Mm-hmm.
Yes,
Professor Stadler?
yes, you can see that. But then always you have, as a physician, reflect, is it mycosis fungoides, yes or no? And then you have to take biopsy. So if your patient tells there are lesions coming and going, then you have to question if it comes up more often than once a time, then you have to question what kind of lymphoma you see and what is the final diagnosis.
Mm. That brings up a very good point. Maybe we can you can talk a little bit about the importance of biopsies and why do we need to do a biopsy? What does that tell us? And how often do people have to have additional biopsies over the course of time, or is it just at initial diagnosis? How does that fit into the diagnosis and then ongoing treatment? Do you rebiopsy after a while?
That is a very, very important question. You have to make a picture of the patient, not only macroscopically, also microscopically, and even more in the future on a molecular level. And so you have to biopsy early. And from all the last studies we know, you have to take 2 biopsies from 2 different lesions to get the whole scope of the development of a cutaneous T-cell lymphoma. And in the course of the disease, and especially if lesions change and patients change, or the response to treatment is not as expected, you have to rebiopsy. And in addition, in early cutaneous T-cell lymphoma, there is a huge differential diagnosis. And just looking to the slides, it's very difficult to judge between atopic dermatitis and cutaneous T-cell lymphoma. And then you have to do additional work up with T-cell receptor rearrangement, also molecular studies, to find a definite diagnosis. Because we have pharmacies for atopic dermatitis which would harm an early cutaneous T-cell lymphoma. So the diagnostic has to be very precise.
Mm.
I would echo that as well. I think, you know, the clinical picture of an individual patient is so important about where you biopsy, when you biopsy.
Yeah.
And I've been reflecting so much on this very recently. And if you think about the data we're getting from a Proclippy study from early stage patients, and also, so if you think that in terms of the diagnostic delay for mycosis fungoides, on average 3 years and 3 biopsies before a diagnosis is made, and that's, you know, a startling statistic. But also, again, you know, to echo the point, I think it's more important now than ever, with the new agents coming on, especially for atopic dermatitis, that we really emphasize the importance of clinical pathological correlation for individual patients. And if there's anything atypical about an eczema, that a biopsy should be taken.
Yes, I think that's always the challenge, right? When, why did it take so long? Why even if you do the biopsies, why can't you give me a diagnosis? And I think that is always a question for patients, and it's challenging because it's complicated. It's not an easy one and done. Yeah. Okay, we have a question here for Professor Stadler. Can you explain why staging is not always explained to the patient? And is there a consensus on staging?
In general, yes, we have our international guidelines. We updated our staging. It's somehow depending on the country where you are living. But basically, staging you do, as we just discussed, most important, the biopsies. We have ultrasound. You do a CT scan. You do once, as a basic, you do fax analysis. to see the differentiation of the T cell in the peripheral blood. And that is baseline. Then you can make a staging with T, N. So you have the T classification, how huge is the distribution. Then you have the lymph nodes, the blood, and in advanced disease, the organ involvement. So that had to be clarified just from the beginning when you start, so that all the data of each patient are comparable wherever he is seen by a physician worldwide. So he knows the patient was in stage 1A or B or whatever. So we have the same language all over the world.
So there is consensus for staging. So wherever you are, and I think that's, go ahead.
In previous times, there was also bone marrow biopsy. So we skipped that because it's not necessary to do such a procedure in cutaneous T cell lymphoma.
Mm-hmm.
I think on relation to that, I think, there is a consensus regarding staging, but I think the difficulty then is explaining that in a meaningful way to patients, that they understand the stage and how that implicates, how that influences their overall treatment and their disease course. It can be, it's difficult for general dermatologists who aren't specialists in cutaneous lymphoma, and it's even more difficult sometimes then to convey that across to patients in a meaningful way. So I think there's probably some work that we need to do around that.
Good point. Good point. Yeah, and I think if a patient is initially diagnosed with the cutaneous lymphoma, sometimes you don't hear anything else. It gets very complicated. You can't even, it's like, what's the name of this thing that you just said that I had, that I thought I had? Eczema or psoriasis, and now you're telling me I have this strange lymphoma. I think it sometimes takes a while, like for patients, I know for myself, to wrap your head around all these different pieces and parts, but it's an important component to understand from a patient perspective where you are, and then how the therapies then come depending upon the stage that you may be in. Hopefully that helps answer some of that question. But again, feel free to put your questions into the chat. So we had a couple of questions around Mogamulizumab, and I'm going to try to roll them together because I think it's related to what we're learning now that Mogamulizumab, for some of you, it's a newer systemic agent that's used for more advanced cutaneous lymphomas. It's been recently available throughout Europe and in some other countries. And we're learning things now that it's out of clinical trial and in broader use related to what we're calling moga-associated rash in some patients. And how do we know what is the rash associated with the therapy versus progression of the disease, or should you stop treatment if you have the rash? What are we learning about this specific therapy and this specific side effect? I know there's been a lot of studies and interest in sharing, so I don't know what you might be able to share with the patients who either have had the experience or kind of what we're learning about this.
That's most important to explain patients this very sophisticated therapy with this antibody. It's not an immediate reaction due to the infusion of the antibody. It's a delayed reaction of the host against his lymphoma. So it's a specific immune reaction from cytotoxic T lymphocytes, which are reactive against the skin. And they can simulate a number of other inflammatory diseases. like interface dermatitis, sarcoidosis, or whatever. And patients benefit from this Mogamulizumab associated rash because these cells kill the malignant cell pool. And there are several reports that patients with dramatic disease went into complete remission. However, if this is suspected, so primarily the patient should be educated from the physician who introduces Mogamulizumab. And the physician should know that in 25% of the given substance, you can expect Mogamulizumab rash after a delay of 3, 4, 5 months of therapy. And then this Mogamulizumab rash, or this rash, has to be biopsied. And then also the information from the physician to the pathologist or the dermatopathologist has to be written down. This patient receives Mogamulizumab, and I suspect not progressed in cutaneous T-cell lymphoma, rather than it's simulating inflammatory disease. Please, can you confirm? And in addition, you can also look for the T-cell receptor rearrangement. You can quantify, and then you see that you will rarely find any more malignant T-cell population in this biopsies. So this is a very sophisticated diagnostic, and it should be known by the physicians who treat patients with Mogamulizumab.
Thank you. And I'll just also state, this came up recently with our medical advisory council, and we're looking to create a patient-focused kind of a fact sheet on the Mogamulizumab associated rash, just for patients so they can understand, to take maybe what you've just said and put it into a written format so we have that available and explain. Because I think, you know, should you stop treatment? Should you continue? You know, it gets very fearful from a patient perspective when it may feel like it's progression, but reality, it could be a very good sign that the therapy is working well. So
that's right. It's a good sign that the therapy works well, and only in severe reaction patterns then you will stop Mogamulizumab. Otherwise, you will rather continue and treat this rash locally. Yeah.
From a practical point of view, I suppose just reflecting on how things are done here in terms of who's delivering the Mogamulizumab, who's delivered by the hematologist. I think in terms of that, I think it's important to make sure your dermatologist is fully, you know, aware of what is going on with your skin just prior to going on Moga, so that you have a good baseline, the dermatologist has a good baseline handle on what your skin is like. So if the dermatologist is then called upon by the hematologist who are delivering Moga, that they know and are confident that this is what it was like now and this is what the changes are. I think that's quite important, certainly from our practice here in Ireland, because we just started giving Moga here.
Yeah, and it's our newest therapy that has become available. So we're continuing to learn more and more as it's used more and more around the world, which is very exciting. Let's see, let's go to perhaps something more practical. What can help with the itchy and sometimes burning skin when you've got rash all over? Any recommendations for how to manage that intense itch and sometimes burning and challenging parts of the disease? Dr. Molloy, you want to jump in here?
Yeah, I tend to use the acronym CPR. So CPR is cleanse, protect, and repair. That's the way I tend to explain skincare treatments to my patients. In terms of cleansing the skin, I think it's something to use something that is very gentle on the skin. It's very individual. I tend not to be terribly prescriptive in what people use. If they find something that works for them, I advise them to stick to it and try not to chop and change things too much. But I think in terms of cleansing, mycosis fungoides can get infected, just to ensure that the crust and everything is off the skin as best they can. In terms of protecting the skin, that's where a moisturizer is very, very important. It can help. Now, when the skin is broken and inflamed, if you put on a moisturizer, something that can make things a hell of a lot worse. It can really sting and burn when you put that on. So again, it's about finding something that suits you. Things that are a bit greasier, ointment-based moisturizers tend to be a little bit more tolerable, but you have to be careful because weather dependent, in a very hot, humid time of the year, like we're experiencing right now here, greasy moisturizers aren't always the most practical. So you may find you need to rotate your creams or your moisturizers throughout the year, depending on the weather. And then repair is really controlling the disease. So you might be using a little bit of topical steroid or any topical therapy on your skin, just to help alleviate some of those skin symptoms. But I think it's important to find something that works for you and stick to it as best you can.
Professor Stadler, anything to add maybe about managing itch?
If a patient has a very severe itch, then you have to go back to ask the question why. And then you have to look to the blood parameters. What has he blood involvement? And and then if he had blood, we just talked about moga, then he would be a candidate of systemic therapy, because then with this compound, pruritus drops immediately if they're, and the most severe pruritus is associated with blood involvement. But on the other hand, Kevin, the most important is to have a line in the external therapy, and ointment is almost better than creams. And then you have to all these at least in disseminated disease, the microbiome plays a most important role coming up even more in the next years in our understanding where are the driving force. And then you have to clean and to take regular basis a shower to clean your skin, and then to take an ointment just to take the integrity of the skin is most important for the benefit for each patient.
Great. Thank you. All right, I have a couple more questions, very interesting questions in the chat. So, so we have a physician who's with us, but her daughter is 12 and she has ALK-positive cutaneous lymphoma. She's being treated in France, in Marseille. And her question is, any pediatric specialists in cutaneous lymphoma? Given it's rarer in children, I don't know if either of you have any thoughts on treating a child, particularly with ALK-positive cutaneous lymphomas, and how that might be different for a child versus an adult, or how to find the best care in that instance.
I would recommend for this patient and for his parents to go to Paris to Martin Bargot's department to establish and question the diagnosis. What is it? What it is really, and then do a plan for this child, maybe, and especially in childs, the biological behavior is different to adults. We know that from pediatric cutaneous T-cell lymphoma, that most of these cases are not going further into disseminated cutaneous T-cell, so they resolve when they get into the adulthood. So this would be my recommendation, and to see how we could make a treatment plan for this young girl or boy.
Mm-hmm. Great, thank you, thank you. Yeah, and I'll also say, interestingly, there are it's a small cadre of pediatric dermatologists who have an interest in cutaneous lymphoma, who are starting to come together to address this very small and very unique population. So hopefully we'll have some more data and things of that nature.
Yeah, important is it's a CD30 lymphoproliferative disease, and this has to be worked up. And there should be the first question: is it waxing and gaining and so on? So that are also key questions for just from the clinical point of view, and then you get a feeling of the biological aggressiveness of such a CD30 lymphoproliferative lymphoma.
Great, thank you. Thank you. Okay, let's see. The use of topical corticosteroids during several years tends to make the skin weak and thin. Sometimes tiny bumps or scrapes cause injury. The weakness of the skin can the weakness of the skin be recovered by stopping the use of the steroids? Or is there a strategy that can facilitate the use of the topical steroids and take advantage of the benefit, but avoid the damage? That's a good question.
A very, very good question. It's a difficult one to answer. I mean, I suppose what you want to try and do is to use the least amount of topical steroid you can to give you symptom relief or disease control, bearing in mind that topical steroids probably don't really have any, anti-mycosis fungoides effects as such. But I think what I tend to do, as I always advise, is moisturize the skin first and let it soak in for 15-20 minutes before applying the topical steroids. And that comes from work done in patients with eczema. There was one study that showed that if you do use that strategy, you end up using 50% less topical steroid over time. So you probably end up using less topical steroid on your skin than you would do normally. So I think moisturize first is a good strategy, and then apply your topical steroid is the way I would tend to do it. But I think you have to be careful, because once the skin is thin and there is atrophy of the skin, you have to be quite careful in the strength of topical steroid that you're using, because there's less depth needed for that topical steroid to penetrate the skin. So your physician may actually reduce the strength of topical steroid that you're using on your skin to penetrate down into the skin. Don't you think, Rudy?
Yes, I agree totally what you said. We don't cure cutaneous T-cell lymphoma with steroids, and more is not better, or often twice a day is not better. It increases the harm of the skin, and if they have striae distensae, that's irreversible. So that is then a stage you can't reverse. So as we know from atopic dermatitis, there are a lot of recommendations to do interval therapy. So you as Kevin said, you use ointment or creams for some days, and then do interval therapy, 1-2 days of steroid therapy, and then continue without steroids. And then we have old steroid compounds and newer ones, which their relationship to atrophy is better than what we had before. So this should be also be taken into account if you treat a patient with steroids.
Yeah, and the other thing from a practical point of view, I always tend to ask patients in my clinic is what benefit they're getting from topical steroids, because actually, are they using it as a moisturizer on their skin? And actually, that's the only benefit they're getting from the topical steroid, or what exactly what is it helping, or what is it improving, to try and rationalize how much they're actually putting on their skin, and if a moisturizer on its own might be enough to help with whatever symptom or disease control they're looking for.
Great. Great. Okay, so we have about 10 minutes left, so I'm going to try to condense a couple of questions. So our friends in Denmark ask, why does it take so long to get a diagnosis? And it's kind of a two-part question, then how can we educate maybe the general dermatologists who might see the patients first before getting to a specialist, to make them more aware? And then that kind of goes to, how can we bring more awareness to cutaneous lymphoma in general, right? To help with that diagnostic journey.
I think because I'm newly back in Ireland, I think that's very applicable to me, particularly at the moment, in terms of raising awareness around cutaneous lymphoma here. I think to the first part of the question, in terms of why does it take so long, but one, I think, cutaneous lymphoma, it's a rare disease, and general dermatologists may not be aware of the disease as often as the specialist is, or that their eye isn't quite as trained to look for those subtle signs of cutaneous lymphoma. And even taking a biopsy may not always give you the answer straight away. And actually, if you look at the diagnostic criteria, actually, that's the clinical picture that's most important in terms of making that diagnosis, because we can't make a concrete diagnosis of cutaneous lymphoma on a biopsy alone. It's the clinical, how it looks on the patient and the biopsy, to allow us to make that diagnosis. In terms of, certainly since I've come back to Ireland, I've been campaigning around the country in terms of cutaneous lymphoma and actually raising awareness, at a local level and a national level, to really, get people thinking about the disease. And it actually has had a tremendously positive impact, I think, in just a short space of time, just by talking about the disease and making my dermatology colleagues aware, and also hematology as well, more aware about the disease, and actually get people starting to think about the disease and what are we doing, why are we doing it, and are we doing the right thing, or can we do things better?
And I know, Professor Stadler, that's actually what you're doing right after you leave us today, is doing a presentation to the dermatologist there in Germany at your meeting about cutaneous lymphoma. But any additional thoughts?
Yes, the problem is the awareness, to create the awareness, and the general practitioners are not educated, and they don't have the view on this specialized skin presentation of cutaneous T-cell lymphoma. And in the beginning, it's also difficult for specialized to really establish a definite diagnosis. But in general, you can say to the general practitioner, if you have what you call eczema, and this doesn't in 2, 3, 4 weeks respond to anything, then you have to refer to a specialist, and then and ask him to do the right diagnostic steps to come closer to the definite diagnosis. And in some cases, it's really a problem, because just in the beginning, there are only few tumor cells. The reactive pattern around these few tumor cells creates a clinical picture, and then it's very difficult to define these very early lesions. So that rare disease have to go to competent centers, and in each country they have to define where are these people, physicians who are engaged for this orphan disease, and then you can continuously improve. And what you are doing is much exciting, helpful, to give this awareness to all patients all around the world, in each country.
Yes, thank you. And we have a lot of things happening. There's a big global awareness campaign that's going to take place next year to try to do this. And so
maybe a suggestion to make a color, like a color fold of early cutaneous T-cell lymphoma pictures. This could be, and then the patient could go to the physician. Look, I got that from our self-help groups from the world, and could it be what can we do to rule out or to establish the diagnosis? So this would be, I think, somehow helpful.
Great, thank you. Okay, I know we have a couple of minutes. I have two more questions. One is regarding the difference between follicle center lymphoma, which is a B-cell lymphoma, and folliculotropic cutaneous T-cell lymphoma. And they've been diagnosed with T-cell, well, it says follicle center lymphoma. Now, I don't know, it's hard to say specifically, but I know it gets confusing. And it says the disease is only in the scalp, which leads me to believe it's folliculotropic cutaneous T-cell lymphoma. But
No.
or not.
No. These are two different distinct entities. We have to explain the patients. Our immune system is based on two cell lines, the T cells and the B cells. And then we have the different types of T-cell lymphoma associated with the skin, and also B-cell lymphoma. And one of the most B-cell lymphoma, cutaneous B-cell lymphoma, is the follicular cutaneous center B-cell lymphoma. And the predominant location of this cutaneous B-cell lymphoma is the scalp. And then you have to differentiate the follicular T-cell lymphoma. These are aggregated T cells primarily concentrated around the hair follicles, and that's most different.
So important for the person to find a specialty center.
It's a specialty center, and if he has this cutaneous follicular B-cell lymphoma, it's very good, curable. It had a good prognosis for him, so it's good for him.
Great. Okay, and our last question, which I think is perfect to finish up with, was around a specific new therapy that's in clinical trial from France. I believe that is from Innate Pharma. But I think in general, maybe since we only have a couple of minutes left, with regards to what's coming down in new therapies and clinical trials for cutaneous lymphoma, what do you see as the next thing that might come to fruition?
That could be lacutamab. That is the KIR antibody, which is studied so far in phase 2 studies. But this is phase 2. Then comes phase 3. So I think it will last at least another 2 years, I think, or 2 to 3 years, that this compound would be going into the market. So that would be my expectation of lacutamab. So far, we have to optimize, we have two compounds, the fusion toxin, brentuximab vedotin, and the newer one is the Mogamulizumab. Now we have to do the work to optimize, to use Mogamulizumab for all our patients. And we have this compound, and it is, in my eyes, a certain game changer, but it has to be used in a correct way. And it will help the patient. And then we have, which will be new, maintenance therapy we did, and we concluded a huge study and showing that the patient will benefit from maintenance therapy with an HDAC inhibitor. So this study met his final results and could be approved in Europe at the end of next year for the treatment of patients.
Great. Dr. Molloy, any thoughts on what's coming through the research pipeline?
I was just going to echo what Rudy just mentioned about our current new therapies. I think the journey for those is certainly for MOGA is kind of beginning, and the question really is how we combine those therapies and how we use them optimally. to control the disease.
Great. Well, I think we're right at the bottom of the hour. So thank you all for joining us. Thank you for your questions. Thank you for your wonderful answers. Thank you for joining us today. It's really been an honor and a pleasure to have you both with us. And now we have a little half-hour break before our peer-to-peer time together where we get to chat with each other. And thank you all for bringing your knowledge and your wisdom and answering everybody's questions. And thanks everybody for your great questions and for your time and attention. So we'll see you back here in a little bit. Thanks everybody. Have a great, we'll see the patients back here for a little while, but thanks everybody for joining us. Have a great rest of your day, everyone. Take good care.